Key points in CPR are algorithm, effective chest compressions, and determination of the reversible cause 5H5T. When the defibrillator arrives, attach an EKG monitor and it can be distinguished into shockable rhythm or non-shockable rhythm as algorithm. Algorithm VF-PVT. Shock biphasic 120-200J is recommended by the manufacturer as soon as possible. At least give chest compression greater than 30 seconds first, unless VF occurs between monitors and defibrillation is immediate, and excessive energy exertion causes myocardial dysfunction. Then resume CPR immediately. Open IV, IO access send blood tests for etiology such as VBG, POCT blood chemistries, POCT glucose. 2 minutes before CPR, have the recorder notify to feel the pulse and charge the energy in advance before each ECG, because if it is PVT, VF, shock can occur immediately. Alternatively, perform chest compressions during charging and resume compressions immediately after defibrillation if organized rhythm check pulse. Subsequent shock refractory arrhythmias can be fixed or escalating energy levels depending on manufacturer recommendations. Max power. Initiate epinephrine 1 mg diluted to 10 ml IVQ 3 to 5 minutes after second defibrillation. Consider inserting an advanced airway, secure the ETT and confirm the location with ETCO2. Administer amiodarone 300 mg IV push or lidocaine 1.5 mg per kilogram IV after third defibrillation. At least 30 minutes 60 CPR should be continued after infusion. Seconds before another shock. If there is physiologic evidence of ROSC, a confirmation interruption in chest compressions can be performed. PEA, asystole. Open IV, IO access, send blood tests to determine the cause as well. Administer epinephrine 1 mg diluted to 10 ml IVQ 3 to 5 minutes as soon as possible. Consider inserting an advanced airway. ECG after CPR every 2 minutes. Check pulse if organized rhythm. 2. Effective chest compressions. Compress the chest 2 to 2.4 inches deep and at a rapid rate of 100-120 per minute, releasing the chest completely. Interfere with chest compressions as little as possible. Don't help breathing too much. Switch chest compressions every 2 minutes. If advanced airway is not in place, give 30 to 2 CPR or 1 breath every 6 seconds. If advanced airway is inserted, give 1 breath every 6 seconds. Use audiovisual feedback devices to control the effectiveness of CPR. Physiologic parameters were used to control the effectiveness of CPR, including quantitative waveform capnography attempts to achieve a minimum PETCO2 greater than 10 mmHg with a target of greater than 20 mmHg. Arterial relaxation diastolic pressure, but no clear figures are available to recommend. 3. Review the cause 5H5T, do a secondary survey, take a history, sample, physical examination, lab, and bedside US to help determine the cause. Hypoxia, hypovolemia, hydrogen ion, hypo divided by hyperkalemia, hypothermia, toxins, tamponade, cardiac, tension pneumothorax, thrombosis, pulmonary, thrombosis, coronary. Thai Resuscitation Council recommends 6H6T with added hypoglycemia and trauma. Narrow complex PI often caused by hypovolemia or mechanical problems such as cardiac tamponade, pneumothorax, mechanical hyperinflation, pulmonary embolism, myocardial rupture. Ultrasound can help diagnose it. US does not interfere with PR. Wide complex P metabolic, drug toxicity, AMI, LV failure. Adjuncts to CPR. Ultrasound may be considered to determine a reversible cause or to view cardiac motion in the P if it does not interfere with CPR, but it is not recommended as a prognostic recommendation for stopping CPR. O2 supplement provides maximum FiO2 during CPR. Sudden increase in ETCO2 or diastolic pressure or arterial waveform indicating ROSC during chest compressions or ECG in organized rhythm. Termination of resuscitation. The BLS TOR rule, consisting of 1 non-witnessed arrest, 2 no ROSC, 2 no shock delivery, was able to stop CPR 20 minutes after resuscitation in the patient who had not been transported. The ALS TOR rule included 1 non-witnessed arrest, 2 no bystander CPR, 3 no ROSC after full ALS, 4 no AED shock delivery. In cases that do not meet all criteria, they must continue to operate. Resuscitation and transfer the patient to the hospital. In patients who had undergone intubation and ETCO2 lesser than 10-20 minutes after ALS had a very poor prognosis. But this should not be the sole deciding factor in stopping CPR. Alternative CPR technique. Mechanical CPR device is considered for use in situations where chest compressions are not effective. Minimize interference with CPR from the installation to start using the device. Active compression decompression CPR and impedance may be used if equipment and personnel are trained. Interposed abdominal compression CPR may be considered if adequately trained personnel are available. Extracorporeal CPR. ECPR may be considered in cases where cardiac arrest is due to a cause that can be resolved for a limited time. Post-resuscitation care, stabilization, ETT placement, keep SBP greater than 90 mmHg, MAP greater than 65, O2 sat 92-98%, PaCO2 35-45 mmHg, glucose 1 to 180 mg, DL. 12 lead ECG emergent cardiac intervention STEMI, unstable cardiogenic shock, need mechanical circulatory support. In comatose, TTM, CT brain, EEG monitoring, and critical care MX. Not recommended prophylactic ATB, seizure prophylaxis. Targeted temperature management. TTM is recommended for all patients who are unable to follow orders. The goal is to keep the temperature constant between 32-36 OC for at least 24 hours. Prevention of fever in patients when TTM is discontinued. Rapid infusion of IV cold fluid is not recommended in the prehospital setting. PCI after cardiac arrest. Emergent coronary angiography in all cases with suspected cardiac cause and ECG with STE in considered and suspected cases. OHCA plus comatose plus cardiac origin STE. Neuroprognostication. Neurological forecasting should use a combination of assessments and wait for enough time to avoid drug effects or during the early post-injury period. In patients undergoing TTM, the prognostic time is usually at least 5 days after ROSC, with minimal interference from sedation. Recovery. Surviving patients require assessment and systematic care and social reintegration recommendations, such as driving, having sex. Analyze and summarize teamwork, including acknowledging the emotional problems that may arise with the team and caring for this group of patients. Specific circumstances of resuscitation. Accidental hypothermia. Rewarming with standard resuscitation is not considered fatal until rewarming unless there is an obvious mortality. Anaphylaxis. Administer standard resuscitation with an emphasis on epinephrine. Asthma. In patients with sudden increase in PIP or difficult ventilation, tension pneumothorax is suspected. Consider reducing RR and tidal volume to reduce the risk of auto-PEEP and barotrauma. During peri-arrest, if auto-PEEP increases or BP decreases, disconnect from bag mask or ventilator and apply chest wall compression to reduce air trapping. Cardiac surgery. In post-cardiac surgery with VT, VF, perform defibrillation 3 consecutive times. If not successful within 1 minute, then start CPR. In post-cardiac surgery with a systole or bradycardic arrest with a pacer wire, perform pacing. If unsuccessful within 1 minute, initiate CPR. Consider sternotomy for post-cardiac surgery within 10 days. Open chest CPR during or shortly after surgery. In patients who do not respond to standard treatment, ECMO or cardiopulmonary bypass may be performed. Drowning. Perform CPR with rescue breathing by resuscitation as soon as possible. Mouth-to-mouth ventilation may be performed in the water. And all who received resuscitation, refer to hospital for observation for at least 4-6 hours. Routine cervical spine stabilization is not recommended. Electrolyte abnormality. Hyperkalemia, IV calcium, sodium bicarbonate 50 mg IV over 5 minutes, mixed 50 grams glucose plus Rye-10 IU IV over 15. 30 men, nebulized albuterol 10 to 20 mg over 15 minutes. Emergent hemodialysis, KXL8 is not recommended. Hypomagnesemia, MgSO4 1 to 2 grams plus 5 DW 50 to 100 ml Sig IV over 15 minutes in cardiac arrest plus QT prolongation. Hypermagnesemia, IV calcium. Hypokalemia, KCl IV 2 mg, min then 10 mg over 5 to 10 minutes. Opioid overdose, naloxone 0 to 2 mg IV Q 2 to 3 minutes. Pregnancy. BZD overdose, flumazenil is not recommended in undifferentiated coma. CCB overdose, refractory shock 10% calcium gluconate 30 to 60 ml IV over 10 minutes, repeat Q 20 minutes up to 4-time high-dose insulin plus glucose, or consider giving IV glucagon or doing ECMO. Cocaine-induced HT, agitation, chest discomfort, BZD, alpha blocker, CCB, NTG, morphine avoid beta-adrenergic blocker. Local anesthetic, neurotoxicity cardiac arrest bupivacaine toxicity lipid emulsion 1.5 ml per kilogram IV over 2 to 3 minutes, then drip 0.25 ml per kilogram divided by min. Digoxin toxicity, antidigoxin fab severe cardiac glycoside toxicity. Co-poisoning, hyperbaric oxygen therapy severe toxicity. Cyanide, hydroxycobalamin 5 grams IV over 15 minutes plus 100% oxygen plus divided by sodium thiosulfate 12.5 grams IV. Please subscribe if you want to see more video.